Good afternoon, everybody. My name is Jenna Webb. I work with SHA Communications, and I'll be moderating the call this afternoon. In the room with me is our CEO, Dr. Scott Livingstone. We also have a number of individuals on the line, but to make introductions and to kick us off, I'll turn it over to Scott.
Thanks, Jenna. Good afternoon, everybody. Before I begin, I'd like to acknowledge that April 28th marks National Day of Mourning in Canada for remembering workers injured or killed on the job. This day is particularly noteworthy this year, knowing the risk and sacrifice taken by our healthcare workforce each and every day to prioritize the health and safety of others. We also know that globally, some of our colleagues have lost their lives protecting people from COVID-19. I'd like to join the rest of Canada in remembering while recommitting to our part in protecting our workforce as best we can. I'd also like to, at this time, acknowledge the death of the long-term care resident who passed away this weekend due to complications of COVID-19. Our sincerest condolences go out to the family and loved ones of this individual. This sad outcome should remind us to strengthen our resolve to combat COVID-19. And while today's presentation is going to offer some encouraging information, I want to emphasize that it does not detract from how seriously we are taking the cases of COVID-19 in Southwest Saskatchewan or anywhere else in the province. I've started my previous updates by saying thank you, and I'd like to continue that trend today. Our healthcare workers demonstrate their commitment to the province through their hard work and sacrifice on behalf of residents of Saskatchewan. I'd like to continue to thank them for their efforts and the work they do each and every day. Today we're providing an update on the modeling efforts for the province with the inclusion of Saskatchewan-specific data. This is an important development as it allows us to more accurately plan for different scenarios in the healthcare system while our efforts to contain, delay, mitigate the virus continue. Modeling serves to ground us in the best data available for our response. From that, our plans can be divided into two parts. Our offensive strategy, which includes broad-based testing, aggressive contact tracing, and better access to virtual care, and also strengthening our defense against the virus by putting plans in place to escalate our capacity to meet the demand as the pandemic may surge. Despite all good news our province has seen related to how COVID-19 spreads, these plans are critically important. We have to continue to plan for the worst while hoping for the best. As we've seen from other jurisdictions, the situation can fluctuate very quickly. That's why we will also share today a plan for monitoring key metrics into the future. The public's understanding of these numbers and how every person's actions contribute to them are critical to help us keep ahead of the virus. I'm joined on the line today by several of my colleagues within the Saskatchewan Health Authority that will provide a presentation both on the modeling and the revised offensive and defensive strategies. Today I'm joined with Dr. Susan Shaw, our Chief Medical Officer, Mr. Derek Miller, the Commander of our Emergency Operations Center, Dr. Jenny Basran, our Senior Medical Information Officer, and Dr. Julie Kryzanowski, our Senior Medical Health Officer. With that, I'd like to turn things over to Derek for the presentation, please.
Thank you for the opportunity to provide an update today on Saskatchewan COVID-19 modeling and also a health system readiness update. Our purpose remains the same. Saskatchewan Health Authority services will adapt and expand to meet projected COVID-19 patient demand while continuing to deliver essential services to non-COVID-19 patients throughout the duration of the event. Today we're going to provide an update in 4 different areas. First being the COVID-19 modeling, reflecting the Saskatchewan circumstances, an offensive strategy update and a defensive strategy update, both building on the information that we had shared previously, and an overview of some of the planning that we're undertaking with respect to resumption of health services. I'm going to turn it over to Dr. Jenny Basran for the modeling update.
Good afternoon, everybody. I wanted to start by acknowledging the partnership that we have with the Computational Epidemiology and Public Health Informatics Lab at the University of Saskatchewan under the direction of Dr. Osgood, who's led the modeling work with us. Next slide. We're going to start with 2 definitions, key definitions that I'll be using throughout the modeling part of the presentation. And these are the 2 key ones that we're going to be using to drive a lot of our conversation. So the basic reproductive number, which is the number that I've been using in the past called the R0, this is the average number of people that one person with the virus could infect where the whole population is susceptible and we haven't undertaken any intervention. And the purpose of the R0 is really to help us understand what we need to plan for as a system. And it allows us to understand the base to run what-if scenarios. And that was the number that we used when we did our modeling presentation on April 8th. What I'm going to be introducing today is something called the effective reproductive number. And this is the actual average number of people that one person with the virus would infect at the current time. So what's happening now after the effect of all the interventions that we've put in place currently and how we've been following those directions. And really what the effective reproductive number will do is help guide decisions around next steps in public health measures. Next slide. So people will, are very curious about how we're doing right now, and the cases are ones that we report out every day. This is a way to look at the same idea of looking at the number of cases, and you can see Saskatchewan is there in the bold green, and we've organized it this way to look at the number of cases per 100,000 people. So to give a sense of ratio compared to other provinces and other countries. And you can see there that we're on par with British Columbia, and we can also see the increasing trends that some of our provinces are still struggling with. So this can show us that we've definitely flattened the curve, and I'm going to reference the hammer in a little bit, but we've flattened it quite aggressively. Next slide. Another way of monitoring to see how we're doing as a province when it comes to adhering to the public health interventions is something called the Google Community Mobility Reports, which anyone can look up, and there's a website there. And this one shows us in Saskatchewan, we've had reductions in going to retail recreation, certainly reductions in transit and workplace, although we do enjoy our parks and have been getting out into the nice weather recently as well. So we can see that we have had a decrease as well as an increase in the amount of time that we spend at home. Next slide. On this website, you could also compare other provinces as well as the Canadian comparison here. And so people can explore and follow along, and this gets updated on a regular basis. And we're fairly on par with the rest of Canada with a few differences around transit and the parks again. Next slide. Well, those are ways of understanding how we're doing. There are limitations to both of the two previous ways of looking at how we're doing. The way that we find is the best way to represent what is happening in the province is something called the effective reproductive number. And this, as I mentioned earlier, describes how well the various interventions are doing at decreasing the spread. And it also reflects how well we as a public are complying with the restrictions in place. And so the goal is to keep the effective reproductive number less than 1. And at that point, we know that this is the tipping point and that the cases are declining. So recalling back that the reproductive number is the number of people that one person that has the virus would infect. So if we can get that below 1, then we know that we're not spreading it as quickly and we're actually on the decline. And so this could really be a major consideration when we're determining what to do with our public health measures. And this is often called the hammer and the dance. So we hammer down the curve with aggressive measures. And then as we release and adjust, it's a bit of a dance where we try to keep it below 1. And I think in the federal announcement earlier this week that they had a nice visual for that as well. We do calculate this regularly. And on April 25th, our effective reproductive number in Saskatchewan was 0.7. This is a bit of a lagging indicator in that some of the cases that we're picking up would have been infected up to 14 days ago. So some of the numbers we're seeing recently would reflect, for example, what was happening on the Easter weekend. However, there are some earlier cases in there as well, depending on when people present. Next slide. And so this is just a visual showing the outcomes of the modeling, showing the effective reproductive number. And you can see with the red line, that's at the 1 mark. And our goal is to really keep that effective reproductive number under 1. And so you can see here that we have been under that point consistently within the confidence intervals since the beginning of April. On the bottom below that, you can see 2 charts that show Germany and Singapore as examples of how they've reduced their effective reproductive number but also showing in the Singapore example that even though you could come down, certain things can happen and the curve would come up again, and then you would adjust your interventions and bring it back down again. Next slide. So now switching over to the basic reproductive number, and this was the number that we'd introduced last time when we were talking about modeling. And this is a number, as I mentioned before, is the average number that one person would, with the virus, would infect in a population where everybody is susceptible and we haven't undertaken any interventions. And just a comparison of the Saskatchewan R0 outcomes to where we were in our earlier what-if scenarios with the different parts of the world. And as I said before, we're now using that number in a model that we have are able to age stratify, and it's been updated with the most recent evidence to provide another what-if scenario of what if the worst case potentially was happening in Saskatchewan. How would we plan for that as a health system? Next slide. So again, remembering that dynamic modeling is not prediction. So the numbers that the model is producing doesn't predict what will happen. That can only be determined by how well we all follow the public health recommendations around social distancing, physical distancing, hand washing, and the various restrictions as we go over the next little while. And so what it does provide for us is the ability to run what-if scenarios to help guide planning, and this will, again, evolve over time. The effective reproductive number, which I introduced today, is really helpful in determining how effective we currently are in the current situation right now, and can be used as a guidepost when choosing which new measures we want to undertake or loosen. It can be considered an early warning system that we share with the public during this dance phase of the hammer and the dance. I think I'll pass it on to Dr. Kryzanowski.
Thank you. So I would like to provide an update about SHA's offensive strategy, which includes strategies to control and prevent the community transmission of COVID-19. Our offensive strategy continues to develop, and it is rooted within our service delivery model of connected care for the people of Saskatchewan, which includes public health, primary care, intermediate care, and continuing care, as well as transitions to acute care when required. In real time, we have our public health and primary care teams responding to cases through the work they do every day. And as the province begins to reopen, care in the community remains the foundation of our healthcare system for prevention, for health promotion, and for primary care when needed. The SHA has already implemented a number of initiatives to support care in the community that will help reduce the burden on the acute care system and ensure that we stay well and healthy. Next slide, please. Included within the community care strategy are strategies to increase testing. Within Saskatchewan, among Canadian provinces, we have among the highest testing rates per capita and also the least restrictive testing criteria where testing is available for anybody with symptoms of COVID-19. We continue to work to scale up availability of testing in sites around the provinces, and new strategies for active case finding, including testing persons who are identified as contacts through public health contact and outbreak investigations, providing outreach to populations who are less likely to seek referrals to testing, and sending consistent messages to public and healthcare providers who are ordering the tests. We have testing sites across the province, including on First Nations communities, and we are also mobilizing new technology which include gene expert testing that provides rapid results within hours. Next slide, please. Our contact tracing surge plan also continues to develop. Within the last week, we have trained staff on a new technology for contact investigation that will help streamline the process and improve our reporting and monitoring. Within Canada and internationally, we are a leader in the adoption of this common application. This technology will help us load level resources across the province so that we can provincially strengthen and continue to locally deliver responses to community outbreaks. And we continue to look to mobilize surge capacity to stay ahead of that demand and respond in real time. Next slide, please. Our community surge plan also provides primary care, intermediate care, and continuing care through assessment and treatment sites that are distributed across the province, through virtual care models with more clinicians and sessions being provided every day, screening and cohorting staff within long-term care as strategies to protect seniors who are a population most at risk for severe outcomes and deaths related to COVID-19, and continuing to deliver services in community. We know that this work needs to be sustained over the weeks and months to come, and we are still early on in our response to COVID-19. We do need to work together to continue to stay healthy and strong and ensure that supports and care are available to those who need it most. Next slide, please. Turn it over to Derek for the defensive strategy update.
Thank you, Dr. Kryzanowski. So with this new modeling information, we have an opportunity to adjust the planning scenario based on the Saskatchewan information. By doing so, we still sustain a conservative capacity estimate and the contingencies to ensure that we are prepared for a worst case potential surge. As well, our response, and this is no change from the previous presentation, it's based on a staged response to patient demand so that we would be activating spaces and capacity in a stepped manner in response to COVID-19 demand. This table outlines the three different scenarios that were previously presented based on looking at the experience in other jurisdictions around the world and also in Canada and North America. You may recall that Saskatchewan Health Authority had identified a mid-range planning scenario between an upper and a mid scenario. And this basically provided capacity numbers in terms of acute beds, ICU beds, ventilators, and other information that supported our planning. As noted, we've now received a Saskatchewan age stratified scenario, and the information is displayed here in the yellow column. And this provides you an opportunity to see an adjustment, and basically it sees the figures and in terms of acute beds, ICU, and ventilators be reduced. So we are adjusting our planning to align with these new figures. It will ensure that we remain prepared for a major surge. It is based on Saskatchewan data and information, and we believe it is more reflective of a potential scenario. And it also allows us to reduce the capacity by about 1,000 hospital beds, 400 ICU beds, and 400 ventilators. I will also point out that the total ventilators in this scenario, it's within the number of ventilators that we currently have within the health system. So as mentioned, at a local level, we are adjusting plans to align with this new planning information. Our plans are still based strongly on the premise of cohorting COVID-19 patients and also responding in a staged way. And this would include any activation of a COVID-19 designated hospital or non-COVID-19 hospital, as well as the ongoing use of mixed hospitals to meet COVID-19 patients' requirements. We are also reviewing the timing and trigger points for the deployment of the plan based on this new information. The SHA response plan continues to include the development of 2 field hospitals, one in Saskatoon and one in Regina. It's based on 2 stages of activation. Stage 1 has a predefined number of beds, 309 total, where we would perform all the base infrastructure requirements to prepare for activation, purchase all the equipment, and then basically trigger the activation of those beds at a certain point as part of the sequencing of our plan. And then we would understand that those beds would become available within a predetermined amount of time to meet steps of capacity requirements. We would also have a stage 2, and this is a contingency capacity that we would plan for and be able to expand services as needed. For example, in Saskatoon, this would see us going from 1 sheet of ice surface to 2, and likewise at Everest Place going from 1 salon within the Everest Place to occupy a 2nd salon, and so giving us a total potential capacity of 650 beds in field hospitals. Saskatchewan Health Authority is working with the Ministry of Health on a health system service resumption plan. Similar to other plans that we've been putting forward, this will be based on a staged approach. We are looking at community services, elective surgeries, and diagnostics that were impacted by the service slowdown that was introduced last month. It will be a cautious and methodical approach to reintroduction of services. Many factors are being considered as part of the development of this plan, including prioritization of highest patient needs, looking at the risk of transmission of the virus, looking at the impact that resumption of services would have on COVID-19 surge capacity, and also the impact on personal protective equipment inventory is a consideration, as well as other factors. We know that we must be able to respond to potential COVID-19 surges in demand in the future, and that is a principal element of this plan. The service resumption plan is something we're working hard on right now, and we will be sharing more information on that when it becomes available. In summary, I would just like to say that the updated modeling information that's provided, it provides good insight into the Saskatchewan specific situation, as well as informing our scenarios that are used for planning. Our offensive strategy continues to support the sustainment of low rates of transmission, but I want to emphasize that the public has the biggest impact on our offensive strategy and its success, and certainly underpins the success that we've seen to date. Our defensive strategy continues to adapt based on the new modeling information, and we will be adjusting that, and we will ensure that we have our defense ready should we need it in the future. The resumption of health services is an important activity that we're planning right now in order to support non-COVID-19 patient care, and at the same time ensuring that we're able to respond to potential surges in the future for COVID-19. With that, I'm going to turn it over to Dr. Shaw for closing remarks.
Thank you, Derek. So I've shared this before, but I really feel the need is there to continue to share it because your ongoing role in this pandemic is so important. No health system in the world can flatten the curve on the growth of COVID-19 without the help of the public. And in Saskatchewan, we have done so well to flatten the curve. And now, as plans are put in place to reopen our province, we need your help even more. Keep washing your hands regularly and teach young children how to wash their hands as well, and continue practicing physical distancing. And it's important to be able that you can identify those people that you have had contact with. Most of all, it's critical to remember that despite efforts to relax restrictions in certain areas, there still will need to be and are many restrictions that we need you to comply with. We may even see increased measures to protect some of our more vulnerable populations. You still have a role in saving the lives of Saskatchewan residents and protecting our healthcare workers. Continue to be mindful of those around you who may have compromised or weakened immune systems, and watch out for them, while always keeping in mind how our actions each and every day can and will save lives. Stay home whenever and wherever possible. The virus is still here. We will have clusters and even outbreaks within the province in certain areas. And we need to remind ourselves that we are all in this together and that these flare-ups or outbreaks could happen anywhere. In a province where football references are indeed plentiful, I have to remind you that we are all part of the same team. Thank you, everyone, for your ongoing support.
Thank you, Dr. Shaw. We'll move to the question and answer portion of the afternoon. I do have some folks in the room with me. If you've got questions, please step up to the microphone. We also have folks on the line as well. Maybe we'll start with a question on the line to begin, please.
We have Ashley Martin with the Leader Post.
Go ahead, please. Ashley, can you hear us? Okay, let's take a question from the room.
This is about the effective number, that 0.7, which we're learning about today. How come we see no modeling or projections for where things could go using this specific figure?
Jenny, do you want to take that question?
Yep, absolutely. So the effective reproductive number is actually a representation of where we are at this current time. So when you're running what-if scenarios, the basic reproductive number talks about how the virus acts, and then in a fully susceptible environment. And so then we can add on, in the what-if scenarios, we can add on different types of interventions, different types of populations, different things like that. And so that the basic reproductive number is critical to run the what-if scenarios. What the effective reproductive number tells us is how are we doing today with the current interventions in place and kind of reflecting people's response to the public health measures. So they're used for two different reasons. So the effective reflects where we are now and not so much used to project into what-if scenarios and dynamic modeling. Does that answer your question?
Yeah, as a follow-up, how do we expect this effective number to change as some restrictions start to lift as spelled out in the reopen plan?
Jenny, do you want to take that one too?
Sure. We definitely will be watching it, and the goal of having the effective reproductive number is to be able to be aware and adjust as we need, depending on both how the loosening of the restrictions work as well as how everyone responds to them. And I think, as Dr. Shaw was mentioning, it's still really critical that we remember that even with the loosening of the restrictions, there are physical distancing needs to remain in place, hand washing needs to remain in place. The core basic transmission prevention strategies that we really want people to remember. So we'll be watching this to monitor and use it as part of the decision making on how we can respond.
Maybe just to add to that, SHA will be publicizing that number every week along with our regular modeling update. So you'll be able to see each week as that number changes. Can I go back to the line? Is there any questions there?
We have Alicia Bridges with CBC.
Hi, I wanted to ask about the early warning strategy mentioned on slide 14. Can you explain what that is?
Is that Jenny?
Derek, are you able to pull up slide 14?
Can you pull up slide 14?
I believe that's the effective reproductive number.
Is that the slide?
Jenny, would you be able to explain the graphic of the early
absolutely.
warning system?
Yeah, so again, just reflecting that the tipping point for when a virus is still growing in the community or when we're actually starting to see the decline is the effective reproductive number less than 1. So if we can get the effective reproductive number less than 1, which we currently have, then we know that the spread of the virus is declining in the community. If we start inching closer to that, then it's a warning signal to say, let's pause for a moment and look at what potentially could be contributing to that and whether or not adjustments need to be made.
Thank you. We'll take a question in the room.
So I just wanted to ask if you can provide any timeline at all for when some of those postponed medical services are likely to come back online, and why are we remaining so cautious on this when we are still quite far from that 3.12 planning scenario that we're working with? I mean, why not use some of those empty beds for people that need hip surgery or need cataract surgery?
So a couple of questions there. So the first one with respect to timelines around when we're going to restart, and I think Derek covered in the defensive strategy and sort of the restart of the system. One of the things that's important is for us to assess what's actually occurred, not just the number of surgeries that have been delayed. So there's been about 3,800 surgeries that have been delayed or postponed because of the gearing down of the system. And one of the things we know, and we're starting to see a little bit of that now, we saw people shying away from hospitals, shying away from healthcare providers because we've created some fear in across the province, and with that we know that there's people that haven't attended facilities when they probably should have, and we're starting to see that happen more. It's one of the things that we've talked about last week is the hospitals are still here to serve you. Until we know and have assessed what's gone on with those people that are out there, whether it's a delayed elective surgery or a delayed procedure or somebody just not being able to see their family physician on a regular basis to see how their chronic disease is doing, you won't see us define an exact time frame. What we're trying to do now is use, just like we have with the data modeling, is use data to help inform where is the best place to open up the system carefully, but also to address the highest needs in our population. The last thing we want to do is start burning through elective surgeries only to have our facilities fill up with people with medical needs that we haven't met or diagnostic needs that went postponed. So we will be developing that plan over the next couple of weeks, and certainly we'll be trying to define that same phased-in approach, but I think similar to, you see that 5-phased approach with no dates around the phase 3, 4, 5. It will be similar. We'll be slow and methodical, and we will use this data, which Jenny has already outlined, to help guide us to see what's going on the COVID, because we still have to balance both responses. So we see these empty beds, and there's lots of healthcare providers out there that are both concerned about what's happening out there in the healthcare community, but also at the same time, there's COVID is not gone. And we, because of such good work of the Saskatchewan population to flatten that curve, the testing is one thing, contact tracing is another, but those public health measures have been what's been so important. And as we lift those, we really have to watch what happens. We can't burn all our capacity to care for patients that we've postponed. We need to maintain that COVID capacity, and that's what we're going to continue to do just in case something happens. But it is for front of mind, and it's a good question.
Yeah, so could I just have a bit more information on how you actually derived the 3.12 number for the R0? I mean, you said it's based on Saskatchewan data, but I thought that our actual data was being used to derive the RT. So how did we get the R0 of 3.12, and how stable is that? Will that stay with us now because it's based on the kind of biological behavior of the virus in our population?
Right. Jenny, do you want to take that question?
Yeah, absolutely. So a lot of considerations been put into trying to determine what the Saskatchewan R0 is, or the basic reproductive number. And so the 3 methodologies that were used by Dr. Oska's lab includes the basic statistical manner with which you may consider figuring out what the R0 is. The challenge with that is that you have to look at how it spreads before interventions are put in place. And Saskatchewan was very good at getting on top of things very quickly. And so that method wasn't as, we weren't as confident in that number. So then we also used artificial intelligence, and Dr. Oskar has a particle filtering model that was able to provide some insights around that it was in that 2 to 3 range and closer to the 3. And then the third method we used, where we did a comparative analysis with how different viruses have spread in our province, and then compared it to other jurisdictions, and then compared the COVID spread as well. So quite a complicated process, and the 3.12 was the number that they came to conclusion with the most confidence. And there are some confidence intervals around that, but that was the number that we chose to use in our updated modeling for the worst case planning.
Let's take another question from the line, please.
We have Chris Vandenbrekel with News Talk 650.
Hi, yeah, I was wondering what the effective reproductive number is in the north and far north of Saskatchewan versus central and southern Saskatchewan.
So that's a good question, and it's one of the things that we can now do, now that we have that number, is we can do some work to create those regions. And I think the team through Jenny and Dr. Osgood are working on that, but I'll let Jenny just follow it up, so make sure that I've given you the right response.
We're always looking at different ways of looking at the data and ways to help with the decision making. And so we absolutely are in the process currently really trying to understand if we can figure out the specific effective reproductive number for different parts of the province, so that that can help guide a little bit more nuanced decision making. And so that work is underway, and we're hopeful that we'll be able to identify that in the near future.
There's a question in the room.
Hi. I'm still having a hard time explaining to people how the revised planning scenario relates to the reality of what we're saying today. Obviously, when you're looking at 250,000 cases in Saskatchewan, when you only have 300, and when you're looking at 3,050 deaths still, when you only have 5, you're looking at a 900-fold increase in such. And people don't understand why there would be a planning scenario of such extreme measures when the tolls are so low right now. So can someone better and more plainly, I guess, explain under what scenario today we might be seeing the revised planning scenario and these numbers? What factors would have to come into play? What would be the situation that would be the basis from this? That it's down considerably from the first scenario, obviously, when we're talking about as many as 400,000 cases and 8,000 deaths, but obviously people don't understand why the planning is being done to this scenario when it's not reflecting their reality.
Okay. So I'll start, and then I'll turn it over probably to Derek to comment, and I'll go back to when we first started talking about modeling and the fact that modeling isn't a crystal ball. It's something that we use to plan, and at the time we were using data from outside Saskatchewan and outside the country, in fact, to do some of this work. I think since those days, we've seen things happen across this country, in Ontario, Quebec, and right next door to Alberta, that is sobering, to say the least, with respect to how the system is preparing itself. I would say that one of the things that stands out for me, Murray, with respect to how we're planning and continue to plan for the surge is, as we move forward with COVID, it's not going away anytime soon. So we flatten the curve. That doesn't mean COVID goes away. That we're going to be flat for a while if we can keep up this good work, and we'll know that by the modeling that we're doing. But we do know from the modeling, if you withdraw, for example, a major component of public health orders or public distancing, the case numbers projected go right up to one of the worst case scenarios. So I think one of the things we're experiencing, and which has been a challenge for all of us in the province through the good work of the public to public distance, is the fact that our success is really what's aggravating folks, because you're not seeing us blow out the hospitals with demand, and you're not seeing cases skyrocket, but that's because of some very intentional things that have been put in place, as we've talked about the three-legged stool, whether it's testing, contact tracing, and now, of course, our severe restrictions around public health. To me, it's really around, the system doesn't turn on a dime. We have a big, complex system. I wouldn't say it was easy to postpone procedures across the province, but it's not as easy to gear them up, and it's not as easy to shift directions if something happens that is unpredictable. We have to prepare knowing that COVID is going to be with us for months, and we have to prepare knowing the system needs to restart, but at the same time, we need to build that capacity. And even if we're not using that capacity for COVID, we may need that capacity for other type of care that we'll be providing residents to ensure the system smoothly goes back into full operation. I know that's not a complete answer to your question, and that's why I'm going to ask Derek to add to that if he could, because I know that they've been through the EOC, they've been looking at the projected numbers, how we use triggers to either escalate care. And I would say that the defensive strategy is a phased-in strategy, and we haven't implemented it across this province. We haven't seen all those triggers. We are seeing it in our bigger centers, Saskatoon and Regina, where we've seen this pullback of services, and that's where most people in the province are seeing. But I'll throw it over to Derek to follow up.
Thanks, Scott. I guess what I would say in response to the question is, as Scott mentioned, it is a significant system, complex system, and putting together the plans and so on to support some kind of planning figure some type of capacity target, we needed to make some decision on what that target was. And we picked conservative numbers the first time we presented this, and because we didn't have Saskatchewan information to really inform that. And now we do have Saskatchewan case experience to feed into the models and drive these new capacity numbers that really support our adjustments to the plan. I guess it's important to look at this as a worst case planning scenario, not as a projection or a prediction of what will come. We all really hope that we don't see anything like this, but we need the system to be able to be prepared to actually respond should this happen. And when we see situations like what you might see in New York or other jurisdictions where things flared up really quickly, we want to make sure that our system is also able to really stand up really quickly to respond to that. So that's what this is all about. It's about getting our system prepared to be able to respond in those to significant surges in demand. And I don't know if Jenny has additional information or context she wants to add in terms of the modeling information.
Yeah, no, I think those are great explanations. I think the only thing to add is, and you pointed this out, Derek, that these aren't predictions. So we're not saying this many people will die or this many people will come to hospital or this many people will actually get COVID. What we're saying is, in a what if scenario, what if the worst case scenario were to happen, how do we as a health system have to be ready to very quickly stand up and get care ready? Because we also know that the death rates and harm to others is worse when we don't have that capacity, when we're not able to calmly be ready and activate. And so the purpose of the modeling is not to predict how many people that we think are going to get it or die in the province. It really is to help plan and make sure that our system is ready and quickly ready to be able to stand up care and provide the best care we can if that worst case scenario were to happen, which we all hope won't happen.
Can you better explain what the what-if scenario is when we are at the point we are at right now? Because once again, the problem being is once you attach actual numbers, I realize that they're not predictive. I realize that they're a what-if scenario. But what's not being understood, I think, by the people that I'm getting questions from is under what circumstances would we have to achieve, would these numbers be achieved? What would have to happen after a month of social distancing or 6 weeks of isolation for us to wind up with these numbers? Would it be a situation where we would go back to right to square one where we were back in February? Can you better explain to people why I guess this is important and why this modeling exercise is still relevant to them?
So I'll start, and I think it's around that slide around the hammer and the dance, and the belief that we have flattened the curve based on what's gone on in the province, the three-legged stool around testing, contact tracing, and those severe public health restrictions. And I would say that the next steps of the what if are going to be determined around how flat that curve stays. And what the model will help us do is on a daily basis, weekly basis, monthly basis, allow us to measure what's happening in the province, whether it's us reopening the healthcare system or the economy continuing on in its phases, and it will inform us. And if we don't stay flat, then we know we're going to have to back off what we're doing with respect to providing more services, and we'll redirect those resources to COVID, and we may have to start instilling more restrictions in the province again. We got here because of the hard work of the people of this province. We're going to stay where we are by the hard work of the people in the province and continuing to test, continuing to aggressively contact trace. But we need to remember this isn't gone. It's not going away anytime soon. And it's really in the hands of the public and the other folks working in the system around how well we do. And if we start seeing it creep up, we will be working with the Ministry of Health and the Government of Saskatchewan to tell them what we're seeing and try to target initiatives so that we can take a step back. It's a lot easier for us, if the worst thing that happened is I was getting crap from you 3 months later from today that we overplanned the system, I'll take that criticism, Murray. I'm not comfortable as we've talked about before, because of some of the things that are happening in the system with respect to perhaps that unmet medical need. And that's why our plan needs to focus on what's really happening out there. How do we open up the system in an informed way so that the people of this province are getting the care they needed when they need it, but they need to get that care safely. Our new normal is a normal with COVID in our population and in our province until a vaccine arrives, and we need to plan that way.
We have time for just a couple more questions on the line, please.
We have Roberta Bell with Global.
Hi, my question is regarding the fact that there's about a 25% reduction in the cases, the caseload that we could see at peak. But in terms of how hard it seems like it's going to hit, it seems closer to like 50%. Like it seems like about 50% less deaths. Can you explain why it seems like Saskatchewan will be hit less hard than you originally thought?
Jenny, do you want to take that one?
Mm-hmm. Yeah, so part of the reason is that the models have been continued to be refined. And so not only do we have better evidence around the number of people that might be impacted, how many people may come to hospital, how many people could, be okay in the community. And then we have that evidence. And then the model that we ran this latest scenario through, and Dr. Osgood's lab has multiple different models and hybrids of models. But the one that we ran this through actually allowed us to age stratify as well. And so what we were able to do is use the age breakdown of the province and run it through that model. And for different age groups, we know the risks are different, and including their use and need for hospitalization. And so that's why the numbers aren't an exact reduction or an exact change from before. This is the ongoing work that we do with Dr. Osgood's lab, and that we're continuously working on improving these models in collaboration with our partners across the country, and as we bring in more evidence. And so it's an ongoing process to try to improve and make sure that we can provide the best what-if scenarios.
We'll take one last question from the line, please.
We have Mark Smith with CTV.
I'm just wondering what the PPE situation is in the province right now. What earlier this a couple of weeks ago, you guys had mentioned that there was about a month's supply left. What's the capacity right now?
So we continue to monitor PPE daily, and we are burning PPE in some areas a lot more than we were a month ago. We still have a month or more of all PPE, even with the continuous masking policy that we've implemented. We have been able to secure those types of pieces of equipment to support a substantial increase in PPE across the province. We're still comfortable where we are, and the supply chain is starting to open up a little bit, but it's still globally, it is not a normal supply chain. We're not receiving everything we order. We're still ordering 4 to 5 times of what we normally order, but we are starting to see things trickle in. As an example, part of our strategy around monitoring staff are the IR thermometers. This week we received 400 IR thermometers, and we're going to be getting another large shipment of those. So those are being redeployed as we speak to our facilities to make sure that we're using the best technology to take temperatures of staff and patients. So we're seeing that. A few weeks ago you couldn't get these things anywhere, but it's starting to open up a little bit. My hope is each week that goes by, the global supply chain starts becoming a little more responsive, but it's been, as you all know, it's been a challenge, but we are still in a position where we have more than a month's supply of PPE across the board.
That's all the time we have. Thank you, everyone.